calling a couple times about the healthcare reform bill.
Sure.
So thank you for taking time today with us.
This is my job. This is
Yes.
what we do.
Yes. I'm a local health actuary.
Okay. Yeah, I
here
read
at-
that. So
here-
I'm really fascinated to hear what you have to say.
Okay. So here in Harrisburg, I'm a member of the Society of Actuaries and the American Academy of Actuaries. My job is to predict financial risk, manage risk, projecting future healthcare costs,
Sure.
and then ultimately setting premium rates.
Okay.
I've actually, for the last 5 years, have worked extensively with the Affordable Care Act.
Okay.
So I've been in the health industry for 12 years, as an actuary for 12 years, but have implemented the Affordable Care Act over the last 5 years, filing the rates and,
Okay.
and assessing what we think are the healthcare costs of this population being insured for the first time. So if you don't mind, I'm just gonna kind of go through the letter.
Sure.
It makes me the most comfortable.
Okay.
Actuaries don't talk a lot, so
I guess,
yeah.
The numbers
I don't
talk
think
back,
we've
right?
actually said this yet, but you can imagine we're all extremely disappointed about your vote yesterday. I think that probably goes without saying, but we could start off with, like, we really hope that we would have had an opportunity to have this meeting with you before that vote yesterday, and we hope that maybe the conversation today influences how you consider the legislation as it comes around in various
I understand,
turns.
and I will tell you, the bill was far from perfect. As you probably know, I was a no on the initial bill. I think it's marginally better, but I think it's far from good.
Mm-hmm.
At the same time, I'm sure as an actuary and people that are interested in the healthcare discussion and the healthcare policy and the circumstances, yesterday we found out, for instance, out of 99 counties in Iowa, 95 lost their coverage. Day before, we found out that Maryland's rates are going up 58%, which will be about 100% in 2 years. We found out yesterday that Aetna was pulling out of the Virginia market. So I think in the context, I think it's important to discuss this in the context that the current legislation that we're operating under, from a financial standpoint, from a delivery of care, from a cost standpoint. I just had meetings this morning with people that they get huge $6,000 deductibles, $1,200 a month. They don't have health care because they can't afford it. They're paying it, but they don't get it.
Yeah.
So the point is that what we have now is unaffordable for a lot of people, is failing for municipalities, states. In the 4th district where we live, we have 2 providers left on the exchange, right? We have two companies providing on the exchange.
On the exchange, yes.
On the exchange.
Yes.
And it doesn't look like anything's going to improve in the future. It's not going to be more. I watched Arizona. I looked at their stuff just because their rates are astronomical, over 100% this year increase, and they went from multiple, like 6 providers per county, to every county in Arizona has 1 provider left right now.
So that's probably a good point for you to kind of share your perspective on some of the things
Okay.
he's saying.
Right.
Yeah, no, I appreciate it. And we certainly have followed everything that you've said about, that on the news and, various talk shows. And we've read the pieces that you put out on your website
Sure,
as well. We've been
sure.
following.
Right. Yes. So if I go through this, I just want to talk about just some of the accomplishments of the Affordable Care Act, and then I do want to discuss the costs.
Okay.
Because I don't think you're out in left field saying that costs are a concern.
Yeah.
So even though we might disagree in ideology, you probably know that about this group. I think we have common concerns as
Yeah.
Americans, and I think that we have common concerns about healthcare costs in general.
Yeah.
Not, we might disagree about who pays for those healthcare costs, but I think we can agree that healthcare costs are inflating way faster than any other
Yeah,
sector.
we're doing very little in my mind from the policy standpoint to address the problem of
Right.
cost. What we're trying to do is figure a way to finance it, but we don't talk about the cost of it.
Right, and I would love to talk about the costs. I do think the Affordable Care Act can be amended and added to help with costs, but we'll get into that.
Okay.
I just wanted to start with. I think it's very divisive to continue to say that Obamacare, or I would prefer the Affordable Care Act.
I say both. Some people,
is-
and because President Obama called it Obamacare, some people feel it's okay. So I use both actually.
Well, okay.
It's not meant to be
yes.
pejorative, but
Right. Well, I think it's divisive to continue to use the talking point that it's failing. I think it had a lot of accomplishments, and you can see I just bulleted a couple. Here in Pennsylvania, it lowered the uninsured rate from 10.6% to 6.4%. 700,000 Pennsylvanians have benefited from the Medicaid expansion alone. It's removed exclusions for pre-existing conditions, removed annual and lifetime limits. I just wanted to pause there. That's enormous, even for employer health coverage. Sure. We know people that have employer health coverage, but their children were born exceeding the lifetime limits. Granted access to mental health and substance abuse treatment, which is essential to healthy communities. Another thing we don't talk about a lot is that the Affordable Care Act applies to small employers, sure. Employers with less than 51 employees. It has greatly stabilized the increases for those employers. Before, when, if you had a small business and you had 5 employees, and everyone was healthy, you might get a great rate the first year. Second year, 1 out of the 5 people have cancer. Right. Your rate could go up 300%, which is very difficult to budget. And it causes ethical concerns when you're hiring too, because you may discriminate risk profiles to rate even small businesses. So where I work, we've seen an average of 4 or 5% rate increases annually on small businesses, and has greatly stabilized the market and their ability to budget for those increases. And I'll talk about why that's different for the individual insurance pool in a minute, but at least for the small group pool, it has created that stability. And then on the second page, the last bullet, it's allowed insurers to compete based on quality of care, administrative efficiencies, and hospital or physician contracting, rather than by attracting the healthiest people. So prior to the Affordable Care Act, the only way to stay in business was to attract the healthiest people, because Capital Blue Cross is competing against Highmark. Right. We can't let Highmark get all the healthiest people because they'll have lower rates than us and we'll go out of business. So so that has taken that part out of the equation. And now we're able to focus on just the quality of care, contracting with hospitals and physicians, and making sure that we're getting the best deals, and that physicians and hospitals are not overcharging for services. That's one of the benefits of insurance. And we can focus on administrative efficiencies, which includes, instead of spending time medically underwriting each individual person and asking for medical histories, it's a very at demand rate. Which is more efficient, and in the long term, it stabilizes premiums, because in the long term, maybe 1 year someone's really healthy and they're upset that their premium's higher than it should be, but most people need to use health insurance at some point in their life. So those were just some of the benefits of the Affordable Care Act. So the second point I just wanted to get into was the cost. And I think that should be addressed. I just wanted to point out a few key points about the cost. Some of the legislation was never implemented. Some of the legislation of the Affordable Care Act was not implemented from the start. There was always the public option in the bill. And I think later on, President Obama said, what if we implement the public option just in areas with lack of competition? So some of these rural states where there's one insurer or no insurers, no one wants to insure, why not allow the public option to come in? That would definitely be help for the coverage issue, right? In some of these states. I know, from an insurance standpoint, if we know that there is somebody in a very rural county where we don't have many members, let's say not many people live in that county, and we have 300 people enrolled in our insurance, and one of those people have a very high cost condition, millions and millions of dollars a year, we're going to pull out of that county because we can't afford it. We can't afford to cover that one person because that impacts the rates of
The
everybody
sake of
else.
Everybody else, right.
But there are ways around that, and I think Pennsylvania is even looking into establishing a reinsurance pool,
Okay.
a state-run reinsurance pool that would
When you
cover.
say reinsurance, so that's the state, that's kind of like, almost like the public option, or are you talking about a blind risk pool, or what? I just want to make sure I understand.
So it's different than a high-risk pool. So reinsurance, what the state is talking about right now is establishing a reinsurance pool, which means everyone gets the same coverage. Everyone gets coverage from Highmark or Capital Blue Cross, same deductibles, same benefits, but Capital Blue Cross then submits high dollar claimants to the state. Let's say whatever it is, $500,000, $1 million,
Right.
and the state reimburses the
Okay, so
insured.
then to me, that's what we're describing, I think, as a blind risk pool at the federal level, something along that line, but maybe it's just difference in terminology.
I think high risk pools differ in that people in high risk pools get different coverage often. They may get a less comprehensive coverage. It's a different policy, where this is everyone gets the same coverage, but the insurer is protected against high claimants.
Right.
So I kind of mixed two topics there.
Yeah.
So one that was the public option was not implemented, which would help with coverage and insurers pulling out. The second provision that wasn't implemented was risk corridors.
Mm-hmm.
So that was when the Affordable Care Act was implemented, we knew that it was going to be an unstable, unpredictable market, very difficult for actuaries to predict because we've never had it before. And people are getting insured for the first time.
Because they had no idea what risk you were taking on.
Right,
Yeah.
no idea. Yeah. So risk corridors was a provision originally in the Affordable Care Act that protected insurers from mispricing. So they could enter in the market and for the first 3 years be somewhat protected against completely missing the ball.
Right.
So that was never implemented, which created a lot of instability in the market and insurers becoming scared and pulling out quickly. And so one of the reasons that this market is so unstable, especially in the beginning years, is something called pent-up demand. So we don't see that. So when I said the small group market, how it stabilized premiums, and those people are seeing very low rate increases, that's a very different market than the individual market, because those are most likely people that have always been insured.
Right.
The individual market consists of a lot of people who were never insured or haven't been insured for years. So when someone goes 10, 20 years without insurance, something called pent-up demand arises where they need medical services. Think about a knee replacement surgery. They might need it for 10 years, and they get insurance and they rush out and they go and they get that service. It could be the same with contraceptive services, like IUDs, things like that. So you see this rush of utilization in the beginning that wears off over time as people are insured.
What's the time frame for that? What is the expected time frame for the pent-up demand to
It's a new market. I see going into 2018 the rates very much stabilizing. 2017 again, it was a scary time. Markets react. Insurers took great losses in 14, 15, and 16. But now going into 18, I think it's starting to stabilize. And nationwide, when you see 20 million people covered by something, they should veer towards average health. They shouldn't all be the sickest of the sick, especially when people are subsidized to buy health insurance. People get the pool gets sicker and sicker when you take away subsidies, because all of a sudden people that are healthy drop out. Why would you pay for insurance if you're healthy? But when you put subsidies in that adequately cover the cost based on the person's income, they are more likely to buy insurance even if they are average health. So that's why, some of the provisions that we're unsure about, even going into 18, have caused some instability. Insurers don't know what will happen if Republicans decide not to enforce the individual mandate, the tax penalty. Will that cause healthy people to drop out because they no longer have to face the penalty? I think going into 2018, we still have the Affordable Care Act subsidies,
Right.
but we're not quite sure about cost sharing reduction payments.
I think that we're pretty sure at this point that those are going to continue.
We're hoping.
Well, I think the president said they're going to continue.
Okay. I think he's been back and forth on that a lot.
I think in the budget that just passed this week, they continue through September, through the end of the fiscal year.
Okay, so we need to know if they're going to be paid in 18 when we're pricing for 18. Again, I'm mixing a bunch of things, but
it's complicated.
Yeah, but one of the biggest points of why the individual market is so different from the group market is pent-up demand, and other than pent-up demand, the only thing that allows healthy and unhealthy people to enter the pool is subsidies, because subsidies are going to be the only thing that get healthy or average risk people into the pool.
So, subsidies have been ongoing, and even under the new bill, subsidies continue.
Right, but less. Right. So they're tax credits.
Depends on your age.
I was going to say, and they're age-based and
Yeah.
not income-based,
Right.
which seems concerning.
It
seems like an age tax.
It's concerning for me as well. Like I said, the bill wasn't perfect. It's one of the things that I complained about. You can, you can have somebody that's older but very wealthy, and they're getting a tax, they're getting a subsidy, and it
Right.
seems
Yeah.
Right.
incongruent.
Yeah, and we want to get as many people insured as we can. So that's why I'm a proponent of the income-based subsidies. That caps how much people will pay towards their health insurance at 10%. I think if you are under 400% of the federal poverty
Right.
level, that really incents people to buy insurance and be covered. So another thing I just wanted to talk about, which is the third bullet on page 2, and it goes on to page 3. I wanted to talk about actual costs.
Right.
So while we talk about who's going to pay for what, how do you get people insured, we have a cost problem in this country.
I agree. I agree
in
completely.
healthcare. So point A on the third page. I'm sure you've heard this number before, but the U.S. spends 17% of its GDP on healthcare. The average among high GDP countries is 10%. And the U.S. has similar health outcomes to other developed countries while spending significantly more. So we really want to balance cost and outcomes, health outcomes. And it seems right now we're not in line with other highly developed countries. And there are lots of factors in this, but I just wanted to hit a couple.
Okay.
There are economic incentives. So point B, there are economic incentives such as fee for service, which means that more treatment is always better economically.
Yeah.
So I'm not saying that doctors are not ethical and that they are not doing the best.
Exactly
right.
what you said. They're incented to do it, whether it's through malpractice insurance requirements, or whether it's pain management requirements, or what they're incentivized to treat more.
Right, so it's not just cost incentives, it's legal incentives, like you said. Point C, a lifetime of treatment is preferable to a cure, and this is again economically. For example, pharmaceutical companies profit tremendously from diabetic supplies, such as insulin pumps and monitors. Funding a cure is not an economic priority. Pharmaceutical companies are the ones funding research. They have very little economic incentive to fund a cure to diabetes. Point D, amenities and marketing. Hospitals spend an increasing amount of money on amenities in order to draw business. And by amenities, I mean, really high-tech centers, beautiful lobbies.
Right.
But amenities do not necessarily translate into better care. Point E, again, I'm going to beat up on pharmaceuticals. There is a lack of trade. Patients can only buy American. And I know that that's an issue that has been talked about in Congress. And I would be a proponent of trade, especially with Canada. The second point is that pharmaceutical companies have a very high profit margin. Pfizer, the world's largest drug company by pharmaceutical revenue, made 42% margin in 2013. And then the third point is, on average, pharmaceutical companies spend more on marketing than research and development. In 2013, Pfizer spent $6.6 billion in R&D and $11.3 billion in sales and marketing. And then the last point when it comes to cost is just, we need to keep in mind that uninsured populations still incur costs to taxpayers and society in general. Uninsured are significantly more likely than insured individuals to use emergency room for non-emergency care. In 2013, the cost of uncompensated care provided to uninsured individuals was almost $85 billion. This cost is reimbursed to hospitals and providers by government and by private insurance. And then as far as cost to society, just one point to make is, prior to the Affordable Care Act, unexpected healthcare costs were the #1 factor in personal bankruptcy. Severe financial setbacks decrease long-term productivity. So both health outcomes and just enormous financial setbacks, can destroy a family and their long-term productivity and what they're going to pay in taxes.
Absolutely, I don't disagree with you on any of it. Yeah.
Right. So then this is the last point I just wanted to make, is just about healthcare economics in general. So a common talking point in healthcare is government does not belong in healthcare. I would say it's a common misconception that the free market is the best solution to cost and coverage problems. The problem with this is healthcare is not shoes. That's the example I used. Life and health are precious commodities with endless value. One does not make healthcare decisions in the same way as buying a new pair of shoes. Because of this, healthcare costs are not price sensitive, and behavior is difficult to control through cost. So really, if a treatment is going to save my life, I don't care what the cost is. Or if I've had 5 years of treatment, but I need ongoing treatment, that cost doesn't become less, or that treatment doesn't become less valuable to me as time goes on. But once I have 3 pairs of shoes, I don't need more shoes. That controls the price of shoes. It doesn't do a good job controlling the cost of healthcare. So health economists would argue that a mix of free market and government regulation is the best solution. From healthcare economist Thomas Getson, the important question is not whether government or markets are better, but how to balance and blend regulation and competition to optimize social welfare and meet necessary constraints. So that's really what I would like to see, is us, instead of large talking points, overarching, government does not belong in healthcare, Obamacare is failing, address what is working and what is not working with our current healthcare system, with the Affordable Care Act, with insurance companies, with doctors, with all the stakeholders, and address specific issues and work in a bipartisan way. We're all tired of partisan politics.
Me too.
Right. We don't want we don't want to be rooting for a team. We don't want them to put a jersey on and we say no matter what, we are with you. We want to be able to work together as Americans and solve problems and use evidence-based solutions for those problems.
Yeah. So my concern is that the cost of the care is it's always been in there, right? Somebody's paying for it, whether it's the person that can't afford to go to it, that goes to the emergency room, or the person that's buying an insurance policy and paying what many would consider an exorbitant rate. The cost is in there somewhere. Mm-hmm. And my concern, and it remains so, is that we really aren't doing a whole lot to address the cost. We're trying to finance an unbridled demand for for a never-ending request for
Right.
healthcare. And I don't know that we can ever get there. As long as that's the paradigm, right? Like, why does chemotherapy cost $10,000 a treatment if it does?
Right.
That's our service part.
Yeah.
And until we address the issue of $10,000 a piece chemotherapy treatments, we're just going to keep running around the ring about how in the heck we pay for it.
Right.
And that remains my frustration. While, like I said, I didn't think that this was a great effort. My concern, among other things, is that if we didn't do, with all due respect, I think that the ACA is failing. Like, even from the standpoint where you say the pent-up demand, we're going to see that it's kind of finished its course now. We're going to see an end to it next year. When you got the state right below us who had a very similar system to the ACA prior to the ACA, and that in Maryland, their costs are going up 58%. We just talked to the insurance commissioner 2 days ago. Next year, 2018, and when you see continued reduction,
very surprising to me.
Well, I didn't make it up.
Right.
You can, and then you see states where they're just continually losing participation. How long do we wait? Is kind of the question.
Right.
And for and this might be somewhat ideological in some people's mind, but I'm just not. I'm not there with the single payer system, and a lot of people come and say, "Well, we
seemingly our president was praising the single payer system last night."
And I'm accused of being in lockstep with the president.
Well, there you go. I think that on this case, we might think about what Trump had to say about Australia.
I don't praise the single payer system, and people say, "Well, why can't we all just have Medicare?" Medicare is going bankrupt. It's going again. Don't believe me. Go check with the folks that run Medicare, and they will give you the date that they predict it will be bankrupt, and ask them. Even the VA, it's helping to bankrupt our country because we're just continue to find ways to finance an unending request for an infinite amount of health care instead of addressing the cost. And addressing the cost is hard. For instance, when you have vertically integrated now healthcare systems, from the insurance company to the hospital to the doctor, and instead of the doctor saying, "This is what I think you need," because it's all one company, the insurance company is telling the doctor, "This is what you can give this person." I don't think that's what any of us signed up for, or that's what any of us want. This bill didn't address that. And I don't know, and the things that I think that will address the cost, things that you're probably interested in, and I think to a certain extent they're not all the end all be all. But tort reform has a portion of it. Portability has a portion of it. Associations have a portion of it. How the insurance companies act, allowing with some regulation physician-owned healthcare operations. They all have a part of it. All that is saved till another time where we can get bipartisan support.
Is this
the
third, at your town hall, you talked about the third bucket and getting that moved up to the first. How come that didn't happen?
Because we can't get any bipartisan support for it. None.
Because our understanding from that town hall was that you were really not into this healthcare bill at all until that third bucket kind of cost lowering stuff got moved up.
I will tell you, I am skeptical that the third bucket's ever going to happen, which is why people like me demanded to get as much as we could in this bill from a cost-saving standpoint. Because if the third bucket never happens, like, what are we talking about here?
A lot of this to us, and I see a lot of pink out there, feels like a war on women. Like pregnancy is a pre-existing condition, a C-section is a pre-existing condition, but like, why isn't a circumcision a pre-existing condition then? Like, it feels personal. It feels like a bunch of men telling us that we shouldn't have access to abortion, we shouldn't have access to birth control pills, and everything about pregnancy and being a woman is a pre-existing condition, so we should be barefoot and pregnant at home. That's how it feels, and that's why we're so upset.
I understand that's how it must feel, but at the same time I don't, because I think that that's a narrative. You have to be able to listen to both sides and kind of judge for yourself. And if you only listen to the one side, that's going to be the narrative. There are women in Congress. There are plenty of women in Congress.
There weren't an awful lot cheering in the pictures in the Rose Garden the other day.
That vote. Well, I didn't go to the Rose Garden, right? I didn't go to the Rose Garden. I'm not sure what that was about. I would hope it's actually to try and inform the Senate, but I just think it's like we're not that far along. This thing could fall apart pretty quickly. That having been said, this bill doesn't allow for any differences between men and women. And if you're being told it does, I would just encourage you to read the legislation, because it doesn't allow for any differences between men and women. I don't know what else to tell you than that, but those are the
But
facts.
if it allows employer-based insurance to deny access to contraception, it just doesn't even, it takes away services that are essential to women.
But if it makes me buy contraception when I don't need it or want it, why should that be my right? Why shouldn't I be able to make that choice for myself?
I don't understand why an employer should be able to make it for you. So
The employers
that should be a personal decision. But if you work for somebody,
disagree.
but if you work for somebody who has an objection, then you can't get the kind of insurance that you personally need through your employer.
The employer should be able to make choices. This is a free country. We should all be able to make choices. And if the employer is probably trying to buy a series of plans or from a series of plans, and unfortunately they become less and less and less choices. And the employer may make choices based on their religious preference.
Well, this is why government should be in healthcare, because we shouldn't have we shouldn't have to, change jobs to find an employee that will cover our birth control or whatever.
I don't think employers want to be in the healthcare business, but they've been incentivized to be in it, and they've incentivized themselves to be in it to offer coverage to their employees. But I think, all told, unless they're in the healthcare business, they would rather just operate the business they're operating and let individuals empower themselves to get whatever their care they can. And quite honestly, I want to be able to buy whatever care I want to buy that's good for me, and I want the tax incentive as an individual that the business gets. I don't understand why the business gets it and I don't. I want the tax incentive for every single individual so that they can make the choices that are best for them and leave the business out of it. That's what I'm talking about when I say portability. It's not just between states, it's anywhere I go, job to job or state to state.
That sounds more like Medicare for all, but...
Well, I didn't say I wasn't paying for it.
Right.
I didn't say I wasn't paying for it.
Right.
But I should be able to maintain
Which people
it.
do pay for universal systems through a payroll
Taxes.
tax.
We're all paying. We're all paying
Yes,
for it.
we're all paying.
We're all paying for it. The question, that's
Do you
not
think
the question.
healthcare is a human right? Like, do you think we should leave people to die on the streets if they can't afford
of course
healthcare?
not. That's
Okay.
absurd. But don't conflate a human right or a moral right with a constitutional right, because they're two different things.
Agreed.
Okay.
Yeah, I think one of the points why it might, feel like a war on women, or it could disproportionately impact women if states. I don't think Pennsylvania will do this, but if a state does take the waiver for the essential health benefits, one of the first things to go for individual insurance will be maternity care. Prior to the Affordable Care Act, you could not, unless you had employer insurance, you could not buy maternity care.
I don't want maternity care. I have 2 children. We're not having any more. I don't want to pay for
Well, but
maternity care.
that's how
But that's a
Insurance works,
societal.
What's that?
Who's going to take care of you when you're old? If there aren't,
But that has nothing to do with maternity care. We're talking about the cost of
the
their
women who are
children.
having the children need to have them in a safe manner.
No, I agree completely. But I'm not having any more. You're asking me to pay for things that I'm never going to use.
You will use the outcome of that.
Yeah,
Right? Like, they will be your doctors. They will be your...
Isn't that the same logic as saying my kids are all out of high school, so why should I pay?
It's exactly the same logic.
There's kind of been an understanding of, social contract.
Right. There
are public goods.
without a doubt. But there's also personal responsibility. Some people never want to start a family. I mean, some people don't want to do a lot of things. Some people don't want to own a Cadillac, but should we make everybody pay for it?
Well, if we start encouraging everyone to not have a family because they can't afford maternity care, our population growth will decline even more than it's already doing, and our economy will surely be sunk.
We're not encouraging anyone to not
No,
start
I'm just
a
saying,
family.
but if people cannot afford to, so we need to think about, if we have declining population growth, like if we start seeing negative increases in population like Japan, right, we're going to have problems too, so we need...
I understand it's a balance.
and it's also I believe it's a pro-life position.
I'm sorry, you're next to me.
Okay, I do believe it's a pro-life position to care for maternity care and to care for children outside the womb.
I do too.
Yes.
The question is who's going to, the question comes down, it's a simple equation. We all understand the cost is built in, it's how we pay for it.
Right.
And to me, how we drive down the cost of the care.
Yes, I want to do it concurrently. So I want people to have insurance, be covered. I want people to be able to thrive and be well and have jobs and be able to take their insurance where they go, to be entrepreneurs, and at the same time drive down cost. So
we want the same thing. The question is how we get there.
yes,
right? That's the question.
But in the meantime, I want as many people insured as possible, and I think
and so while we say, you know, people are saying
people
it doesn't kick, that's a fallacy. It doesn't kick 24 people.
24 million fewer people will have insurance.
No, 24 million less people are required to. They may choose to stay on. They may choose to leave. So it could be their choice. So we're not kicking them off. So that's number one.
Well,
and while
24,
and maybe we did insure 24 million people that heretofore were uninsured. Now we have a whole other social strata of people that have insurance but have no health care because they can't afford it. Like the people I just met with before you came in. Not the ones directly before, but the people I met with this morning that are paying exorbitant prices that can't afford the care because
do they have it through their employer?
No, some have through their employer and some have it individually. They can't afford the premiums or the deductibles, so even though they pay them, they don't go to the doctor.
Right.
That's not helpful either.
Right. And I think there are solutions to that, and I do applaud
and that's
the
what
Pennsylvania Insurance Department on the
on.
reinsurance pool.
So we're working on these things.
Okay.
It's not perfect. It's not done by a long shot. And like I said, it's an imperfect situation. I'm looking at the context that we're in, where people are losing their coverage and losing access, and we're compelled to act at some point.
Right. I mean, this bill in its current form increases deductibles.
Well, we don't know
out-of-pocket
because there was no
costs.
cost. There was no CBO analysis before this bill was
voted on.
voted on.
There was no CBO analysis for a couple of the recent amendments. There is a CBO analysis for the base bill, and we do have the Milliman analysis of the amendments, which show the cost coming down dramatically between the blind risk pool and the waivers.
Okay, I haven't seen the Milliman analysis.
Okay.
But just with a few changes that we're even making for 2018, that President Trump put through HHS, deductibles are increasing.
I don't know. I'm not going to dispute. I don't
Right.
know that, so I'm not going to dispute.
But he promised that they would not, and he promised he would never cut Medicaid, and he's cutting it by $880 billion.
I don't know what he promised on Medicaid. I didn't make the promises. What he
So-
did is what he did.
Right. So, yeah, I thank you for hearing our concerns today, and I know we've gone over our time, but we appreciate it.
I'm concerned about the
Yeah.
same thing.